Thank you for all of you for joining us today. I have the pleasure of introducing Dr. Jennifer Ligibel from the Dana-Farber Cancer Institute. Like many of you, we were hopeful this was going to be in person today, and we will be meeting on Zoom. So we're excited to have Dr. Ligibel with us. For those of you that don't know her, she's one of the senior physicians and an associate professor at Harvard Medical School. She's well known for her work involved with diet and exercise, particularly in breast cancer. And I would imagine we're going to hear about some of that work today, but has done a lot of work related to lifestyle factors such as physical activity, body weight, and how this impacts cancer risk and outcomes. She's well known for her work with the Alliance for Cancer Clinical Trials, as well as with the Translational Breast Cancer Research Consortium, and as part of the Senior Advisory Board for the TREC training workshops at Yale. So Dr. Ligibel, we're thrilled to have you today. Thank you for joining us.
Thank you so much, Dr. Blaise, and I am sorry that I am not here in person. I guess this is just the world we live in now, but I will do my best to make this interesting, even via Zoom. There are three primary sections of my talk today. I know it's kind of hard sometimes to listen for 45 minutes to Zoom, so kind of breaking this up into three pieces. I'm really going to start with thinking about the observational evidence. Why are we interested in connections between obesity, inactivity, and dietary quality and the risk of developing mostly breast cancer, but I'll weave other cancers in as we go along, but into the risk of developing cancer as well as outcomes once people develop early stage, potentially curable malignancies. And then we'll move into what do we know about the impact of changing these behaviors, of losing weight, exercising more, changing diet on the risk of developing cancer or the risk of cancer recurrence and mortality after the disease is already developed. And then I'm going to finish with a little bit of information about what's happening in the clinic around these types of factors. Are doctors talking about them? And then kind of finish up with a sneak preview of some new guidance that may help guide some of these discussions in the clinic in months to come. So with that introduction, kind of go back to the rationale. Why are we interested in diet, exercise to potentially reduce the risk of cancer or improve outcomes in early stage disease? And I think that most people have been aware for a long time about the relationship between obesity and the risk of other chronic diseases, cardiovascular disease, diabetes. The relationship between obesity and cancer risk is a bit more recent, and you'll see that this seminal publication in the New England Journal of Medicine was published a little bit less than 20 years ago, and this was really one of the first large-scale efforts to look at the relationship between excess adiposity and cancer risk. This study followed a cohort of almost 1 million Americans for 16 years and looked at the relationship between their body mass index and the risk of developing a fatal cancer. So it combines both cancer risk and cancer outcomes, and really looked at how especially higher levels of adiposity were related to the risk of developing a fatal cancer. The authors found first that individuals in the highest levels of BMI, and often in this analysis, that was either a BMI of greater than 35 or greater than 40. So these are higher levels of obesity. The individuals in those higher ranges of obesity had an almost twofold risk of developing a fatal cancer as compared to individuals with a body mass index in the normal range. The investigators then went on to look at how body mass index was related to the risk of individual cancers. And they found a number of malignancies for which these individuals with higher body mass index had a higher risk of developing and dying from cancer. And that increase in risk ranged from about a twofold risk of things like postmenopausal breast cancer, gallbladder cancer, up to a sixfold risk of developing and dying from endometrial cancer. So this study was very important in that it led to literally thousands of other reports looking at the relationship between some measure of excess adiposity, usually body mass index, but sometimes waist-hip ratio or percentage of body fat, and the risk of developing cancer. In 2015, the International Agency for Research in Cancer brought together an expert panel to review this evidence and try to determine whether there were consistent patterns that excess adiposity was associated with increased cancer risk. So over the course of about a week, we reviewed more than 1,000, mostly prospective cohort studies, but some case control, and found that there were 13 malignancies for which there was a clear and consistent relationship between excess adiposity and a higher risk of developing that cancer. This list includes a lot of things that, a lot of cancers that are pretty common, things like colon cancer, breast cancer, but also some of the more fatal malignancies, things like pancreatic cancer and ovarian cancer, where there was a clear relationship between higher levels of adiposity and increased cancer risk. For the first time, there were also some myeloid cancers, things like multiple myeloma, also related to obesity. Now, we recognize that obesity occurs because of an imbalance between the energy that is taken in as food and the energy that's expended through physical activity and metabolism. And there's been a lot of work looking at not only how obesity is related to cancer risk, but also the factors that impact obesity and lead to its development. And this is especially true for physical activity. Although there have not been 1,000 studies like there are looking at excess adiposity, there are a growing number of reports that suggest that physical inactivity is also linked to a higher risk of developing cancer. This is one of the larger studies that has looked at this. It was a pooled analysis of 12 individual prospective cohorts of patients without cancer throughout the United States and Europe. It was more than 1.4 million individuals that were followed for 11 years of median time. In that time period, almost 200,000 cancer cases were diagnosed. And in all of these cohorts, physical activity was assessed before patients developed malignancy. And what they found was that, again, there was a list of cancers, many of which overlapped with the cancers that we just saw in terms of the relationship with obesity and cancer risk. But there was a list of more than a dozen cancers for which inactivity was linked to a higher risk of cancer incidence. Now, because there was a lot of overlap between obesity and physical inactivity, adjustments were made to adjust for body weight. And they found that in 10 of these 13 cancers, there remained a significant relationship between inactivity and cancer risk. And in fact, they often found that the higher risk of cancer related to inactivity was in normal body mass individuals. They found that 10 of these cancers continued to have an independent relationship with inactivity and increased cancer risk, even after adjusting for body mass index. So we recognize that obesity, inactivity, poor dietary quality, although diet is a lot more complicated to study than either obesity or inactivity, we recognize that rates of obesity and inactivity are increasing around the world. And this has an impact on cancer incidence. In 2012, which was the last year for which data were available, it was estimated that almost 4% of new cancers around the world were specifically attributable to excess body mass. And that equated to more than 500,000 new cancer cases. There's a couple of interesting things about the relationship between obesity and cancer risk. One is that the excess risk of cancer associated with obesity is higher in women and in men. And in fact, about 5.5% of new cancer cases in women are attributable to obesity, whereas only about 2% of new cancer cases in men. I think the other thing that is very clear from the observational data is that the proportion of new cancers that are attributable to obesity differs around the world. In some places, that proportion of cancers is pretty low, and that's especially true in the developing world, in places where smoking rates are higher. But in the Western world, the proportion of cancers attributable to obesity is much greater. And when you look at these maps here, You look at men and women, and the darker the color, the higher the proportion of cancers that occur are attributable to obesity. And you can see in men that that range is about 3.1 to 5.5% in the higher risk countries. Whereas in women, in places like the United States and in certain parts of Europe and in South America, almost more than 10% of new cancer cases are attributable to obesity. The other thing that has occurred as obesity has become more prevalent around the world is that the timing of cancer incidence is also changing. And this has been especially demonstrated for colorectal cancer. At one time, colon cancer in individuals between 20 and 49 was pretty rare. And you can see on this graph that over time, colon cancer cases in younger individuals has become more common. Now, this is certainly multifactorial, and I don't mean to imply that this increase in the risk of early onset colon cancer is only due to the increase in body mass index. But this work that was led by colleagues Kimi Ng and others at Dana-Farber and throughout the Harvard system demonstrate that having a BMI of greater than 30, having weight gain in your early adolescence and in your early adult life are some of the strongest risk factors for the development of early onset colorectal cancer. So clearly, as body weight shifts around the world, this is having an impact on cancer incidence. But we know that obesity and related factors don't only affect the risk of developing cancer, but they also seem to influence outcomes in individuals who are diagnosed with early stage, potentially curable malignancies. And this has especially been demonstrated in breast cancer. This meta-analysis looked at more than 80 studies that evaluated the relationship between a woman's weight at the time that she was diagnosed with breast cancer and her risk of dying from breast cancer or other causes in the ensuing years. And what this meta-analysis demonstrated was that individuals with obesity, so a body mass index of greater than 30 kilograms per meter squared, when they were diagnosed with breast cancer, had a 35% higher risk of dying specifically from breast cancer and a 41% higher risk of all-cause mortality compared to individuals with a BMI in the normal range. One of the other things that was very striking about this meta-analysis was that it was able to look at younger and older women. We've known that obesity seems to be primarily linked to an increased risk of developing breast cancer in women after menopause. But this meta-analysis demonstrated that the relationship between obesity at the time of breast cancer diagnosis and the risk of breast cancer related and overall mortality was actually stronger in younger women than older women. We don't completely understand these differences, but this has been seen now very consistently, not just in this meta-analysis, but in a number of studies that specifically looked at outcomes in women participating in clinical trials of different types of chemotherapy and endocrine therapy. So poor prognosis in early breast cancer is associated with obesity really across the spectrum of ages. We know that obesity is not just linked to outcomes in breast cancer, and there's growing evidence that in prostate cancer, for example, in individuals who are treated with radiation, treated with androgen deprivation therapy, that higher levels of BMI are associated with an increased risk of cancer progression. This has also been seen in endometrial cancers and other malignancies. And similar to the relationships between obesity-related factors like inactivity and increased cancer risk, we also see that activity patterns and physical fitness are related to outcomes in individuals with early-stage malignancy. The graph you see on the left-hand side of this slide were data that were gathered by our cardio-oncology group at the Brigham and Women's Hospital, and it looked at cardiorespiratory fitness and cancer-related mortality in individuals diagnosed with early-stage malignancies. And what they demonstrated was that individuals with low cardiorespiratory fitness, so these were individuals who had undergone stress testing generally for other reasons, but individuals with low cardiorespiratory fitness had a much higher risk of cancer-related mortality compared to individuals with high cardiorespiratory fitness. Other studies have looked at exercise patterns after cancer diagnosis and have demonstrated that individuals who are more physically active, who are engaging in regular recreational physical activity, which is what we think of as exercise, seem to have a lower risk of cancer-related mortality. And this has been especially demonstrated in breast cancer, in prostate cancer, in colorectal cancer. So very strong observational evidence that obesity and related factors are related not just to the risk of developing cancer, but also to outcomes in individuals who are diagnosed with early stage disease. But the question is there anything we can do about this relationship? Can we modify behavior? Can we put somebody on a diet and exercise program that will either reduce their risk of developing cancer or will improve their outcomes once they've already been diagnosed with the disease? Unfortunately, there is not the very, very large body of data that there were for the observational studies looking at the relationship between these factors and cancer outcomes, but there are a growing number of interventional trials which attempt to look at whether a change in these factors will change the risk or the outcomes of cancer. At this point, the strongest evidence that weight loss specifically could reduce cancer risk comes from bariatric surgery studies. Now, these are not straightforward randomized trials. Unfortunately, although there's a lot of effort to conduct large-scale bariatric surgery trials, most of the data relating to bariatric surgery and cancer comes from prospective cohorts where individuals who undergo bariatric surgery are matched by age, by gender, by BMI, and by comorbidity status to individuals who don't undergo bariatric surgery. So bariatric surgery is a huge intervention, so it sort of fits in this part of the talk, but kind of goes in the other. But as you can see here, individuals who undergo bariatric surgery have about a 30% lower risk of developing malignancy of all types after they undergo the procedure compared to individuals who don't. And as these cohorts have matured, it's been possible to not just look at overall cancer risk in relation to bariatric surgery, but to look at the risk of individual cancers, and especially those cancers which we've been talking about as being related to obesity. This was a cohort through the Kaiser group, and this has been one of the groups that's been the most active in this research. It included 22,000 individuals who underwent bariatric surgery and 66,000 matched controls. The investigators first demonstrated about a 40% reduction in the risk of developing cancer of any type in the individuals who underwent bariatric surgery. They demonstrated a significantly lower risk of colon cancer and almost 50% reduction in endometrial cancer, and significant reductions in things like pancreatic cancer and postmenopausal breast cancer in individuals who underwent bariatric surgery. So some really exciting, provocative evidence that weight loss could reduce the risk of developing cancer. But again, not a randomized trial. And unfortunately, we don't have a large-scale randomized trial that looked at the impact of a weight loss program on cancer risk. But we do have some secondary analyses from studies that looked at the impact of weight loss interventions on other outcomes. The largest of these studies that's been reported to date is from a trial called the Look Ahead study. So this was a study that was developed to look at the impact of weight loss on the risk of cardiovascular events in individuals with type 2 diabetes. So this study enrolled 5,145 individuals with type 2 diabetes who had a BMI of greater than 25 and randomized them to usual care, including diabetes support and education, or to that usual care plus an intensive lifestyle intervention that was developed to help individuals lose between 7 and 10% of their body weight. The study was about 13 years long, so it was a very long-term intervention. The primary outcome was a composite of fatal MI and stroke, non-fatal MI and stroke, and hospitalization for angina. But when they developed this trial, they were very interested in cancer incidence as a secondary outcome. Here you can see the weight loss over time. So this intervention was very successful in helping participants lose weight, and they lost almost 10% of their body weight in the first year. And although there was some weight regain over time, there remained significantly different weight loss in the intervention versus the control groups. Now, unfortunately, the intervention did not meet its primary endpoint, and there was not a significant reduction in cardiovascular events, but they continued to follow this cohort of patients over time for cancer incidence. And again, this was pre-planned, and the way that they had initially designed this was that they were going to look at the relationship between group assignment and overall cancer risk, and then the risk of obesity-related cancers. One thing that happened as this study was in progress was that that list of what was an obesity-related cancer changed. And so they did a couple sets of analyses depending on what cancers were in or out of that list. After about 11 years of median follow-up, there had been 684 cancers in this cohort of around 5,100 individuals. They first of all found that there was really no significant difference in the risk of overall cancer incidence. So about a 7% reduction in the weight loss arm that was not statistically significant. But when they looked at obesity-related cancers, there was about a 20% reduction in the risk of obesity-related cancers in the weight loss group. Whether that was statistically significant or not really depended on the list of cancers that were included. But this was really some of the very first evidence that a diet and exercise-based weight loss intervention could potentially result in a lower risk of developing cancer. Very underpowered analyses, but they looked at some of the individual malignancies for which obesity has been consistently defined as a risk factor. And you can see that there was an almost 50% lower risk of pancreatic cancer, very exploratory, small numbers of cases, and an almost statistically significant reduction in the risk of postmenopausal breast cancer. Unfortunately, that is about what we have in terms of randomized trials or other interventions looking at the impact of weight loss on the risk of developing cancer. But I am happy to say that there are a number of trials now ongoing looking at the impact of weight loss and other types of intervention on the risk of cancer recurrence in individuals who are diagnosed with early stage diseases. And we're going to spend a couple of minutes thinking about some of these trials, but I want to give you an overview. So 3 of these studies, the breast cancer weight loss trial, the Diana-5 trial, and the Success-C trial, are all studies that look at the impact of changes in diet and exercise on the risk of cancer recurrence in women with early stage breast cancer. So this breast cancer is certainly the malignancy for which we are going to have the most information about changing lifestyle patterns after diagnosis and how that impacts cancer outcomes. There's one study, the challenge study, that is looking at the impact of exercise on the risk of colon cancer recurrence. There's one study in prostate cancer, and this study is actually a bit different than the others in that it focuses on individuals with metastatic disease, looking at the impact of exercise on overall survival in men living with castrate-resistant metastatic prostate cancer. And finally, the last of these randomized trials is a trial called the Libs Trial, which randomized individuals with stage 2 to 4 ovarian cancer who had been successfully debulked and randomized them to a diet and exercise intervention or to a usual care control. So in aggregate, these studies over the next decade will really help to provide some more concrete data about the impact of changes in diet and exercise, weight loss on disease outcomes in early stage malignancy. The only one of these studies to date to have reported any outcomes is a trial called Success-C. And these findings so far have been presented only in abstract form, so I'm only going to spend a couple of minutes talking about this trial, but it is an interesting study design, I think, in terms of trying to learn about lifestyle in the context of other ongoing research in individuals with malignancy. So Success-C was a trial that enrolled patients with stage 2 and 3 breast cancers in Germany and randomized them first to a anthracycline containing chemotherapy regimen or to a non-anthracycline containing chemotherapy regimen. But there was a secondary randomization for individuals with a BMI of at least 24. And this was about 2,300 of the 3,600 patients had a BMI of at least 24. They were randomized to a lifestyle arm, which was a diet and exercise intervention with the goal of achieving weight loss, or to a usual care group that just got general, non-tailored recommendations about healthy diet and exercise after cancer. The women who were assigned to the lifestyle group have received telephone calls over 2 years, about 20 calls over the 2-year period, and again, focusing on increasing activity and consuming a healthier diet. So these data were presented now a few years ago at the San Antonio Breast Cancer Symposium. They looked at the 2,300 women who had undergone that secondary randomization. Now, at baseline, women had a BMI of around 28. And I think it is worth pointing out that the BMIs of women in this study are fairly different than the patients that we often enroll in studies in the United States, where our average BMIs are quite a bit higher than they were in this German cohort. They looked at the weight loss that was achieved in the 2 different study arms. So the women who were in the weight loss program, the lifestyle intervention, lost about 1 kilogram. And the women who were assigned to the other program, the usual care group, gained almost 1 kilogram. So that was about a 1.3% weight loss, a 2.6% weight difference between the 2 groups, which is a relatively modest amount of weight change, but was statistically significant given this large population. So unfortunately, when the group presented their long-term outcomes, they found that there was no impact of this weight loss intervention on either disease-free or overall survival. But notably, they unfortunately did experience some difficulties with the trial, in that more than half of the women who had been assigned to this weight loss intervention arm dropped out of the program before the 2-year period, and only about 20% of the control patients did. So these 2 analyses that we're looking at were intention to treat analyses that included all of the patients on the study. They performed some non-protocol pre-planned analyses that looked just at the patients who actually finished the 2-year either intervention or control program, and showed some significant improvements in the women who were in the intervention group. But again, this was not pre-planned, and it was a bit selected given the very differential dropout between the arms. And I do think that unfortunately, this presents some of the difficulties in conducting large-scale trials like this, and unfortunately doesn't really provide us with an answer to the question of whether losing weight after being diagnosed with breast cancer will improve outcomes in individuals with early stage disease. So I wanted to spend just a minute or 2 talking about a trial that we are currently leading through the Alliance in Clinical Trials for Oncology called Be Well, or the Breast Cancer Weight Loss Trial. This study has a design somewhat similar to Success-C in that it enrolls individuals with early breast cancer who have a BMI in the overweight or obese range. But this study has some important differences, and we're hoping that this will help to better answer the question of whether losing weight after breast cancer diagnosis has an impact on long-term outcomes. So the study was designed as a standalone trial. So there's no pre-part of this where women received chemotherapy as part of the study. We did stipulate that people had to receive standard treatment, but we enrolled them after the completion of their adjuvant chemotherapy and radiation. The study was designed to enroll 3,136 participants with stage 2 and 3 breast cancer. Patients were ERPR positive or triple negative, but not HER2 positive. And this was based primarily on data that were available at the time, suggesting that in the HER2 positive cohort, body mass index was not as strongly related to outcomes. There have been updated data since the study was designed, suggesting that there is a relationship between obesity and poor outcomes in women with HER2 positive cancers. So I think, unfortunately, that will not be a question that we can answer in our study, as those patients were not included. The other thing that's important about our trial is that our body mass index criterion is a bit higher than it was for Success-C. And this really does reflect kind of different obesity patterns in the United States and in Canada, where this trial is being conducted. So patients need to have a BMI of at least 27 kilograms per meter squared to take part in the study. They're randomized to a 2-year health education program plus a 2-year telephone-based weight loss intervention, or to a health education alone program. And the intervention is also a bit more intensive than Success-C. There's 42 phone calls over a 2-year period, and we'll talk a little bit in a second about the structure of the intervention. This trial is being conducted through the North American NCTN and NCORE network of academic and community oncology clinics, and is a joint effort through 3 different branches of the NCI. So our primary outcome of this trial is to assess the impact of this weight loss intervention on invasive disease-free survival, which is sort of a common endpoint that is used across breast cancer clinical trials. And we wanted to make this as similar as possible to studies looking at endocrine therapy or chemotherapy. We're also very interested in looking at the relationship between weight loss and these outcomes. Is it the people who lose weight that do better? Looking at the impact of the intervention on other outcomes, and then looking at whether this intervention has the same outcome in younger versus older women and in patients with different kinds of tumors, especially hormone receptor positive versus negative. The study has an 85% power to detect a hazard ratio of 0.8. This equates to about a 4% difference in events between the 2 groups. And it was, again, powered very similarly to the way that we develop adjuvant clinical trials that test other kinds of interventions, primarily drug interventions in early stage breast cancer. We have a number of correlative studies looking at health behaviors and patient-reported outcomes, looking at body composition, and then we'll talk a bit more toward the end of this talk on some of the translational science and the mechanisms through which we think obesity may impact cancer outcomes. So this study is still ongoing, so there are not outcomes to present, so we're not going to spend a lot more time on this other than to talk very briefly about the conduct of this type of very large randomized behavioral trial in individuals with early breast cancer. So one of the things that we recognized early on was that in order to be able to conduct a trial like this through the cooperative group system, we needed to develop an intervention that was delivered centrally. So we have a call center at Dana-Farber. Each patient is matched with a coach. They receive 42 calls over 2 years. Initially, the calls are frequent, and then they go to monthly in the 2nd year. We developed standardized intervention goals. Patients are given materials and support to lose up to 10% of their body weight through cutting calories and increasing physical activity, which sounds easy, but anybody who's ever gone on a diet knows it's not, especially when you're trying to do this all virtually. So we've done a lot of things to try to make the intervention work for different patients. One of the things that was very important to us was that we enrolled a very diverse group of patients, both geographically, economically, racially, ethnically. So we developed ways to individualize this intervention by providing people with tools, things like wireless scales and cookbooks, and also using something called a toolbox concept. So if a patient was struggling with a particular piece of the intervention, there would be additional tools or alternatives that we could use to help optimize weight loss for the individual patient. The other thing that we did was built a robust technology platform that allowed patients to see in real time what their weight was, what their exercise looked like, as well as to facilitate our calls with patients, give them secure email, and give us the ability to record calls so that we could make sure that the intervention was being delivered in a similar fashion across the patient population. So our study status to date, the study is still ongoing, but we did complete enrollment now about a year ago. It took us about 4.5 years to enroll what ultimately ended up being 3,181 patients. And you can see that we had a lovely enrollment curve just about to April of 2020. And then things got a little bit more difficult, but we were ultimately able to complete our enrollment. It took us an extra 6 months, but at the end of the day, enrolled our full study cohort. We also were very excited that we passed an interim analysis in early 2019 that demonstrated significant weight loss between the two groups. The study was set up that if this weight loss differential was not at least 4%, the study would stop. And so we don't know how much above 4% it was, but the study remained enrolling at that point. We ultimately enrolled patients from more than 600 sites across the United States and Canada and have 27% of our participants as racial or ethnic minorities. So very excited about the diversity of our patient sample. And we are hoping that we will have the primary results from this study within the next 2 years. So we're actively following patients. We have 1 more year of the intervention for those patients who were enrolled in 2020, early 2021. And then we will hopefully have more definitive information about the impact of weight loss on breast cancer outcomes. So I'm going to shift gears a little bit now. And I think obviously these large-scale trials that are going on will provide some important information about how lifestyle change impacts outcomes in early breast and other cancers. But one of the things that our group has really been interested in as well is not only does this work, but why does it work? And much of the work in Be Well, as well as earlier trials, really focused on these biologic mechanisms. Why does it make sense that losing weight or exercising more would have an impact on something as complex as cancer? And how can we really leverage these large-scale trials to learn as much as we can about these mechanisms? So this is a very complicated slide, and I think sometimes that the more complicated the slide is, the less we really understand about the exact mechanisms through which something works. We know that obesity has an impact both systemically as well as locally in the area of the tumor. And this is especially true for tumors like breast cancer and colon cancer, where the cancer really grows in an area that's surrounded often by adipose tissue. We know that there's a lot of different pathways that are impacted with something like obesity. There's higher levels of inflammation. There are higher levels of growth factors and metabolic pathways. We know that obesity has an impact on the immune system. And so we've been trying to untangle these factors in studies that we've conducted leading up to the Be Well study. And this is just, I'm not going to show you the studies and studies and studies that have looked at how these factors are connected to cancer outcomes, but this is just a brief snapshot showing that things like fasting insulin and metabolic syndrome are related to increased risk of recurrence and death in early breast cancer. We also do know that weight loss and other interventions impact these pathways. And so this was a small study that we conducted leading up to Be Well that was a clinic-based weight loss program. It was a pilot in 60 patients with early stage malignancy, randomized to an immediate intervention or control group. And what we found was that the intervention was successful in leading to weight loss, and was very successful in changing these types of biomarkers that have been linked to cancer outcomes. So you can see here that individuals who took part in the weight loss program significantly reduced their insulin, their leptin, their adiponectin. So demonstrating some of these systemic changes that occur with weight loss. But the thing that we were the most interested in was, well, what happens at the level of the tumor when somebody changes their behavior? And this was a study, again, leading up to the development of Be Well that we conducted to try to get at what happens in human cancer with changes in energy balance. There's a lot of research in animal models that if you have an animal lose weight or exercise more, it actually changes proliferation and apoptosis and gene expression. But these are hard models to test in people. And so we developed a study called the Pre-Operative Health and Body Study, where we enrolled women who had just been diagnosed with an early stage breast cancer before they had their primary surgery. We collected tumor tissue, and then we enrolled women in either an exercise intervention or a mind-body control program. Our goal was to see whether exercise had any direct effects on breast cancer in humans the way that it does in animals. And this window of opportunity model allowed us to intervene in whatever the period of time would be between their enrollment in this study and their definitive surgery. Sometimes that period of time is only a week or two. Sometimes it's up to a month or more for patients who are having more comprehensive surgeries and reconstruction. So our objective was to look at the impact of this intervention on tumor gene expression, serum biomarkers, and quality of life. The exercise program was very similar to exercise programs that we had used in other studies, and we decided to focus on exercise rather than weight loss for this trial because exercise is something that you can start very quickly. You can get an intensive period of time in a short period, whereas weight loss often takes longer to make 2 weeks of weight loss is not going to do a whole lot for most people. Patients took part in both supervised and home-based sessions, and our control program was really something that was selected by the advocates that we work with at Dana-Farber, who felt that in this very vulnerable period of time, putting a patient into a control group would be less appropriate. And so patients who were in our control program used a program called Prepare for Surgery, Heal Faster, which had been shown in other studies to have favorable quality of life effects, but no effect on serum biomarkers. And we were thinking that if it didn't affect serum biomarkers, it would be less likely to impact tumor-based biomarkers. So these were the patients who took part in the study. So this is obviously a much smaller study than Be Well. It was a total of 46 women who had recently been diagnosed. They were enrolled through Dana-Farber and Yale. We found a mixture of tumor hormone receptor status as well as HER2. And patients participated in this study an average of about 1 month between the time of their initial enrollment and the time of their surgery. We found first that there were significant changes in exercise, and you can see again that our exercise group was able to increase their exercise by more than 200 minutes a week, which was very exciting, and we saw a much lower increase in exercise in our controls. We did not see significant change in body mass index, so we were really able to separate out the effect of exercise more specifically. And we did see some changes in serum biomarkers, and we had primarily included these to show that there was biologic activity of even such a short intervention. We saw significant reductions in leptin and a trend toward a significant reduction in IGF-1, no significant change in our other biomarkers. But what we were most interested in is looking at tissue biomarkers. And we found through KEGG pathways analysis that individuals who took part in the exercise intervention had upregulation of 18 pathways, whereas there was no upregulation of any pathway in the mind-body group. And what we were most excited about was when we looked at the pathways that were upregulated, we found that most of them were around inflammation and immunity. So we found upregulation of cytokine-cytokine receptor interactions, NF-kappa B pathway, things like natural killer cell-mediated cytotoxicity, antigen processing, and T-cell receptor signaling pathways. So we then went on to look at whether there were any changes in immune infiltrates before and after this exercise intervention. It is important to point out that these were primarily hormone receptor positive cancers where there are fewer immune infiltrates. And so this was very exploratory, but we did find that there was downregulation of FOXP3 in the patients who were randomized to the exercise group. And FOXP3 often suppresses the immune system. So this was a small study and certainly needs to be confirmed in larger reports, but this was one of the first trials that ever looked at the direct effects of an exercise intervention on breast cancer in humans. And we were very excited to see these early findings. All right, and I recognize that I am running a little short on time, which often happens when we're talking about these topics, and I do want to leave some time for questions. So I think we will go more quickly through the correlative science for Be Well. And again, patients are enrolled in this study after they have already had their primary surgery. So primarily, we don't have the ability to look at the impact of exercise directly on breast cancer tissue in Be Well the way we did in that prehab study. But what we're really hoping to do in Be Well is to be able to connect these dots, to be able to serially measure these biomarkers to see what changes systemically as individuals lose weight, and how does that relate to the risk of cancer recurrence. So if we see that in women who have higher insulin levels, for example, at baseline, if the intervention is successful in lowering their insulin, that they have a lower risk to have a cancer recurrence, that could help us develop an intermediate biomarker so that we could test more nimbly the effect of different kinds of interventions on these intermediate biomarkers and not have to conduct large-scale trials in thousands of patients to be able to understand the potential impacts of these lifestyle interventions on outcomes. What we're really trying to do is to develop the hypertension or the high cholesterolemia of breast cancer so that we could test a variety of different interventions and figure out what is the best way to favorably impact these pathways to have an impact on long-term outcomes like recurrence and mortality. All right, so from there, I'm going to just briefly talk about some work that we have done looking at, as we've developed all of this observational evidence and there's this emerging data from clinical trials, are these things that doctors are talking about with their patients in clinic? And what types of tools would be helpful to help foster conversations and increase knowledge? So the Asco Obesity Initiative has been an ongoing effort in Asco now for almost a decade that has really sought to increase provider education about the links between obesity, inactivity, and poor dietary quality in both cancer risk and outcomes, and also to provide evidence-based information for patients. I think many of you who see patients in clinic know that there's a lot of information in the lay press that patients will come in asking about things like ketogenic diets and fasting and all kinds of different things. And many times oncologists really don't have answers to whether these things could be helpful, whether they may be harmful. And so Asco has really attempted to develop materials to try to answer some of these common questions. And for those of you who are less familiar with this, there's an obesity toolkit with information that's available to both patients and providers on cancer.net. So over the last few years through this initiative, we've done some work to figure out, are providers addressing these topics in clinic and are patients hearing them? And so in 2019, we conducted a survey of Asco providers. About 822 people responded that sought to understand whether people were talking to their patients about these topics and whether they felt that it was important. Most of the respondents, and again, there's always bias when you have a survey that people can respond to or not, but most of the people who completed this did feel that there was strong evidence linking obesity and related factors to cancer outcomes, feeling that this should be addressed. Many people felt that they didn't have adequate training and that this needed to be a shared responsibility between oncology providers and other specialists in terms of teaching patients about these topics. But what we found most interesting about this survey was that although this was a motivated group of people, most of them said that they felt like this was important and they talked to their patients about it. Very few patients actually referred patients to a dietitian or to an exercise specialist or a weight management program. And when providers were asked, well, what do you think the barriers are to patients making healthy lifestyle change? A lot of them said that they didn't think patients wanted to hear about this. So we then followed up with a survey to patients to figure out, well, what do patients want to hear about these topics? And are they open to making lifestyle changes? So this was sent out through Asco channels, and we had about 2,400 individuals who responded to this survey. Unfortunately, our timing ended up being March to June of 2020, so that may have been bad or good. People were definitely home more on their computers, but definitely distracted with other things. But we did ultimately have about 2,400 patients who responded to this survey. They were predominantly female. About a third of them had breast cancer. About 2/3 of patients who responded had been treated for an early stage malignancy. There was a wide range of when they had been diagnosed with cancer, and about 50% of them were currently receiving therapy when they completed the survey. Unfortunately, the majority were non-Hispanic white. We had wanted a more diverse population, but we were overall happy with the number of respondents. What we found was that in these individuals who completed this survey, about 50% of them were exercising 2 or fewer times a week. 50% of them consumed 2 or fewer servings of fruits and vegetables, and about 50% of them fell into the overweight or obese category. So even though these were people who were motivated enough to answer this survey, they still had a wide range of lifestyle behaviors. We found that most of the surveyed participants indicated that their providers did talk to them about exercise, slightly fewer about diet, and a little bit less than that about weight. Many of them did receive information and advice about exercise, again, less diet and weight, but again, very few referrals even to dietitians, let alone exercise or weight management. And then finally, we found that provider behavior did matter. We found that most of these survey respondents reported that they had changed their diet or exercise patterns after diagnosis. And if the provider did talk about it, patients were more likely to make changes and more likely to be exercising. So showing that the conversations with the provider make a difference. And so just a sneak peek that there will be some enhanced guidance coming soon in the form of an Asco guideline that really tries to give providers the answers to questions about what you should be telling your patients about exercise, diet, and weight management during cancer treatment. So I recognize this was a lot of things. I always get very excited being able to provide an overview like this. But again, hope to leave you with a sense of the large volume of observational evidence suggesting a strong link between obesity and related factors in both the risk of developing cancer and outcomes in individuals with cancer. Emerging evidence that we can change this trajectory with interventions, and a lot more to come on the best understanding of how obesity and other types of lifestyle factors influence cancer risk and outcomes. And I will stop with that to leave a few minutes for questions. Thank you.
Thanks for that wonderful talk, Jennifer. That was a lot of information, and I have many questions, but I'm going to start with a couple that are in the chat. So one of them came from one of our participants asking about, in the Be Well study, how did you determine what diet was recommended? And they brought it up in context of, thinking about soy, dairy, alcohol. Was it really based on calories in and calories out, or did you have specific diets related to body composition changes?
That is a great question, and one that we wrestled with for a long time. We used the diabetes prevention program, the Look Ahead study, and a trial called LISA as the foundation for the diet in Be Well. But those studies were really developed at a time when people thought that dietary fat was really the key driver of weight change. And so we modified, so those studies had sort of fat goals that you shouldn't eat more than X amount of fat. The understanding of diet has really evolved a lot. And so we focused a lot more on calories, but trying to limit both fat and carbohydrates and focus more on whole foods. But the thing that we, at the end of the day, had multiple different dietary plans that people could choose. We had sort of a standard plan that focused on caloric restriction, portion control, but we had a vegetarian form of our diet. We had a vegan form of our diet. We had a lower carb and a higher carb forms of the diet, because our goal was to test the impact of weight loss rather than a particular dietary construct. And we wanted to try to maximize weight loss for the individual person. And so we used a lot of these diets in the toolkit. If a patient was sort of on our standard, trying to limit portion size, limit unhealthy fat, limit unhealthy carbs, and they were still not losing weight, then we would switch over to a lower carb diet. Or if a patient had a dietary preference, we would be able to accommodate that. So the study will not answer the question of whether a particular diet is the best diet. I think that's a different study, but we did collect very detailed dietary records on an ongoing basis from a cohort of about 550 women. So we'll be able to study that in that group.
Yeah, I think that was part of the question. Do you think it's about like the dietary change or weight loss, or is it related to body composition? But it sounds like you said, that might be subsequently answered from a subset of those women.
I will say that there have been a lot of different studies looking at, especially looking at low fat diets that have shown really mixed results. And I think that when there was a study by a group in Colorado that actually enrolled breast cancer patients and randomized them to a low carb versus a low fat diet and looked at the impact of those diets on biomarkers. So it wasn't looking at cancer outcomes. But what they found was that if you lost weight, you had the same exact change in biomarkers, whether you did it through a low carb or a low fat diet. So I think that was, I kind of suggesting that weight may be the piece of this that is the most critical, although we don't know. And there's a lot of really interesting small studies going on now, looking at some of these, changes in eating habits, looking at fasting, looking at ketogenic dietary patterns. Although, to be honest, ketogenic is hard to maintain and it has an awful lot of fat in it that the long-term benefits or outcomes of that, I think, are really to be determined still. But our study just unfortunately will not answer specifically what the best diet is.
Thanks for that. Part of, I think, some of the people you're meeting with later today, part of our team's really been interested also in bariatric surgery. So it's interested in your data around that. And like you said, that's more focused on actually weight loss than, say, particularly a particular diet. Dr. Yee asked, well, noted, weight loss is hard. I think we all would echo that sentiment. How do you feel that we should use FDA-approved drugs like the GLP-1 agonists in clinical practice or research?
I think there's research that needs to be done in cancer patients specifically, because some of the drugs, and not the GLP-1 agonists, but some of the earlier, we all know that there has been a long history of recalls of weight loss drugs, that there have been sort of untoward side effects. There's not a lot known about interaction between weight loss drugs and things like endocrine therapy for breast cancer. There were some early signals in some of the weight loss drugs about increased breast cancer risk in animal models that led to a recommendation that the drugs not be used in cancer patients. So I think that there's definitely work that needs to be done to understand the safety profiles of these agents. At the same time, I recognize that, for a woman with an early stage breast cancer, many times she's going to have more of a risk of obesity related disease in the years following. And so I would certainly not say that you shouldn't use those drugs, but I think that more research really needs to be done to define potentially which drugs are the safest and can be used without any kind of interaction with other medications.
Yeah, I know in the cardio-oncology space that I spend a lot of time in, the GLP-1 agonists come up a lot, both in terms of just not only cancer prevention, but also, or weight management, but in terms of the cardiovascular risk. So it's interesting. And I agree, we need certainly more research in that space. I had a question about whether or not you were looking at markers of aging and cellular senescence within some of the studies like Be Well. As you know, there's a growing amount of literature, not just in sort of inflammation and the tumor microenvironment, but really chronic disease related to that, and how do markers of aging fit into that?
That is a fabulous question. And I didn't have to, I couldn't add yet another slide, but we did just receive funding through a new U01 mechanism for a specific exercise and dietary intervention in older women with breast cancer receiving therapy, and looking at markers of aging, both kind of physiologic markers and then kind of systemic markers is a primary goal of that study.
Okay, great. There is another comment in the chat about a recent meta-analysis in JAMA that showed all-cause mortality increased in people with BMIs over 30. But decreased in those with BMIs 25 to 29 relative to a BMI of 20 to 25. Is going for weight loss in those with a BMI of 28 of lower yield than confining weight loss interventions to those with BMIs over 30?
I think that's a great question and kind of gets to this whole obesity paradox. There was a recent, and I'm not sure if this is there was a recent meta-analysis in JAMA that looked specifically at cancer mortality by BMI, that did also demonstrate higher mortality with obesity in certain cancers, but not in others. And I think one of the things that's really fascinating that is coming forward is that there seems to be a relationship between BMI and efficacy of immunotherapy in certain malignancies. I think the problem with that meta-analysis in JAMA, and it might not be the same one that this individual was talking about, was that it didn't separate out individuals with early stage versus metastatic malignancy. And the data looking at BMI and outcomes in advanced disease is very inconsistent. And I think it's extraordinarily hard to unlink the weight loss that patients develop late in the course of metastatic disease, or when people have comorbidities that impact their ability to tolerate treatment. But that being said, there are some really interesting data in melanoma and in lung cancer and in renal cell cancer that individuals with obesity seem to have better responses to immunotherapy. And that may be because that obesity sort of is a bit of it lowers the immune system's ability to be as effective. So that perhaps by using immunotherapy in those patients, that there's a greater benefit because you're sort of, the immune system has been suppressed to that point. So I think more to learn. There are definitely limitations to observational data in terms of really being able to untangle some of these things, because weight can be so related to disease state, to comorbidities. But it may be that in some malignancies that having a BMI, or just in general having a BMI in the normal range or in the overweight range, is associated with better outcomes. So that was one of the reasons why we limited our BMI and B-Well to 27, recognizing a lot of women do gain weight in that period of time, but not wanting to enroll women with lower levels of adiposity.
Thanks for that. I know we're running out of time. There are a couple of other comments, just one from a cancer survivor saying, thank you for this great presentation. They look forward to watching it again, and really that weight was never mentioned during their whole cancer journey. And a comment with how difficult it is to maintain diet and exercise regimens, especially on top of combating cancer. Do you think that patient mental health and potential counseling can theoretically affect success rates? And is it feasible to incorporate that supplementary treatment and measure on an individual response?
So I think one thing is very clear is that as we are developing these programs, we need to provide support to patients to make these changes. It is completely unfair to go into clinic and say, you need to exercise, you need to lose weight. Like, one of our main goals of something like Be Well is that we can develop the infrastructure and hopefully obtain insurance payment for these things, because it is hard to make behavior change in the best of circumstances. And it can be almost impossible for people that are in the midst of treatment. So we really need to find the right support structures for patients so that we can help them make these changes.
Thank you again for your time. I so appreciate it, and am so thrilled you were able to join us this morning. So thank you again.
Thank you all. And hopefully I'll get to see you all in real life at some point.
Thank you. Thank you, Jennifer.